AUX mode.
Yesterday we were discussing about the space infection. We will continue with that. For the management of a space infection, the goals of management of facial space infection are: the first thing is airway protection. You have to protect the airway, especially in case of Ludwig's angina. Then surgical drainage. Anywhere if there is presence of pus or abscess, the first thing you have to do is incision and drainage. You have to drain the pus. Then medical support of the patient after pus drainage. For say if the infection is in cellulitis stage, you have to prescribe antibiotic as well as painkiller and other anti-inflammatory drugs, followed by identification of etiologic bacteria. For that, whenever you drain the pus, you have to send it for culture and sensitivity so that you know the type of bacteria, and you have to prescribe the antibiotic accordingly after antibiotic sensitivity testing. Okay. So principles of surgical drainage and incision. In case of maxillofacial region, you have to always give the incision in the healthy skin and mucosa when possible. Okay, unlike in other part of the body where the stab incision is given just over the prominent part of the infection and drainage is done. But in case of face, you have to always give the incision in the healthy mucosa and healthy skin and in the dependent part, especially in the region of lower border of the mandible. So place the incision in an aesthetically acceptable area. Preferably, you have to give the incision in the skin creases so that the scar mark will be not visible. Place the incision in a dependent position to encourage drainage by gravity. Dissect bluntly with closed surgical clamp or fingers through deeper tissue and explore the entire anatomical space of the abscess cavity with the opening up of all the tissue planes. You have to always use the blunt forceps or blunt instrument so that you must not injure any neurovascular bundle or other anatomical structures. And be careful that whenever you are using artery forceps or needle holder, you have to insert the instrument in the closed position, and once you enter inside the cavity, then only you have to open and you have to again take it out in the open condition. Don't try to close the instrument when you are inside the cavity, because you may clamp the neurovascular bundle or other anatomical structure. You may traumatize them. Then place the drain and stabilize it with sutures. Drain must be placed into a depth of infected spaces and periodically observe for patterns in effectiveness. Once you have placed the drain, you have to irrigate either BD or TDS. You have to prescribe the antibiotic. Once there is no more pus collection, then you can remove it. Usually the drain is removed after 3 days, after 72 hours, once the infection has been subsided. Incision drainage of submandibular space. If there is submandibular space, if there is accumulation of pus, you have to give the incision at the below the lower border of mandible, about 2 centimeters medial to the lower border of mandible. You have to give the incision only over the skin. Before giving the incision, you have to apply local anesthesia. Okay, you have to infiltrate the local anesthesia over the skin. Then you have to give the incision only over the skin. Don't try to penetrate the blade because you may cut the other anatomical structure. Once the skin is inside, then you have to do blunt dissection, preferably by using any blunt instrument like artery forceps or needle holder. Then you have to separate the platysma muscle. Then you have to reach up to the lower border of mandible. After that, it depends on the type of infection. Sometimes the infection is confined within the body of the mandible. In those conditions, you have to bridge the periosteum. If it is perimandibular space, then you have to drain through the lower border of the mandible. If it is submandibular space, then you have to enter inside the submandibular space after giving incision over or after dissecting the platysma muscle as well as investing fascia. Okay. Once you have drained the pus, the first thing you have to do is, whenever you get the pus, you have to collect it in a sterile bottle and you have to send it for culture and sensitivity. That is the most important thing in case of a space infection. Always you have to collect the pus and you send for culture and sensitivity so that you may know the type of bacteria and the antibiotic which you will prescribe. So based on antibiotic sensitivity testing and type of bacteria, you have to prescribe the medication. Okay. So every time you do incision and drainage, every time you have to send for culture and sensitivity. The bacteria, the type of bacteria may change, and antibiotic sensitivity also may change. And usually what happens once you start the antibiotic, then after second or third days, you usually get the pus is sterile. You can't find any bacteria the infection area once the antibiotic has been already started. So you have to send the pause for culture and sensitivity before starting the antibiotic. Okay. After that, either you may place the drain or you can use a sterile gauze piece. So that it's always better to use a sterile gauze piece. You have to place it over the infected area, then you have to remove every hour, either twice a day or at least once a day. So that you have to remove the infected part, and again you have to change the dressing. And there is submastoid space infection. For if there is submastoid space infection, then you have to give the incision again at the lower border of mandible. The most common incision which is given in the maxillofacial region is submandibular incision. The benefit is through submandibular incision, you can reach to submandibular space as well as submental space, buccal space, submastoid space. Sometimes still superiorly, you can reach up to the temporal spaces, superficial temporal space. Okay. So the most commonly we follow submandibular approach. In case of submastoid space, after giving the incision over the lower border of the mandible, you have to incise the skin and subcutaneous tissue. After doing the blunt dissection, you have to separate the pterygomastoid sling, and you have to enter just below the masseter muscle, between the masseter muscle and the lateral surface of ramus of mandible, where there is pus, where the pus is collected. After doing the blunt dissection, you can see in the instrument, you have to use the blunt instrument, either blunt artery forceps or any other instrument. So you have to enter the instrument in a closed state. Okay. Once you reach the submastoid space, then only you have to open the instrument and you have to come out in the open state. Okay. Don't try to close the instrument when you are inside the cavity, because you may clamp the muscles or other neurovascular bundle and you may traumatize the other anatomical structure. If you clamp the neurovascular bundle and if you try to come out, the artery or vein may tear and it will lead to severe bleeding. And it will also lead to dissemination of infection. There may be chance of septicemia or bacteremia. So you have to be careful. Once the pus is done, the first thing you have to do is you have to collect the pus and again send for culture and sensitivity. Whenever there is pus, make habit of doing culture sensitivity. Never try to prescribe the antibiotics blindly, because the empirical therapy may or may not work. So you have to always see the report, microbiological report, the type of bacteria which is present, and culture and sensitivity for the type of antibiotic. In case of palatal abscess, always in case of intraoral incision and drainage, you don't have to worry about the scar mark. You can give the incision over the healthy mucosa, and then you have to drain the pus. Whenever there is pus, the simple thing is, in case of infection, you have to drain that. Until you do incision drainage, never try to prescribe the antibiotic. First thing you have to do incision and drainage. Once the pus is drained, then only prescribe the medications. Antibiotic is useful only in case of cellulitis stage. Once the pus is formed, the antibiotic could not reach to the area where there is accumulation of pus. So first thing you have to do is incision and drainage, then only it is followed by medications. Another thing, once you have done the incision and drainage, never try to suture it. Okay, you have to do dressing. Okay, at least you have to follow the dressing for 2 to 3 days. When the infection has been subsided, then you can place a suture once the area is sterile. Again, in case of sublingual space infection, as you know, the sublingual space is present between the floor of the mouth, between the submucosa and the mylohyoid muscle. So you have to give the incision over the mucosa near the floor of the mouth. Once you have given the incision over the floor of the mouth, again it's same thing. You have to use any blunt instrument. You have to do blunt dissection. You have to break all the loculi. Once the pus is drained, you have to collect the pus, send for culture sensitivity, then do copious irrigation. After all the pus has been drained, you have to put either drain or you can put any sterile gauze piece, and you have to do dressing for BD or TDS. Once you get the report of culture sensitivity, then you can start the specific antibiotic. So what will you do? Because the culture sensitivity testing report may take at least 24 hours. So what will you do for 24 hours? Whether will you prescribe any medications or not? So after incision and drainage, and before you get the culture and sensitivity report, you have to prescribe the medication that is known as empirical therapy. Empirical therapy means you can use any broad spectrum antibiotics. Once you get the report of culture and sensitivity, then you have to change the antibiotic. Okay. The medication which you use before culture and sensitivity report, that is known as empirical therapy. So you have to use empirical medication, empirical therapy, any broad spectrum antibiotic. Usually in case of maxillofacial lesion, if the infection is contaminated with either skin or maxillary sinus, then we prefer the antibiotic which is effective against Staphylococcus aureus, because the Staphylococcus aureus is present in the skin and maxillary sinus. Okay, so the antibiotic which is effective against Staphylococcus aureus is most common we use amoxicillin plus potassium clavulaniate, or you can use ampicillin plus cloxacillin. If the infection is not contaminated with either skin or maxillary sinus, then in that condition you can use plain amoxicillin. And in case of a stress infection, always try to give IV medications, because IV medications, intravenous medications are more effective. In case of infection, it is a serious condition because the infection may spread and sometimes it may lead to mediastinitis, sometimes it may lead to Ludwig's angina and respiratory obstruction. So in such condition, you can't take a risk. You have to prescribe IV medications. Once the infection has been subsided, then you can change the IV medication into oral medications. So if submental space is also involved, sublingual space is also involved, that usually happens in case of Ludwig's angina. In such cases, you have to drain both intraorally as well as extraorally, and you have to place the drain through and through. Okay. And there is submental space infection. Again, in case of some submental space infection, you have to give the incision near the chin, just below the chin, about 2 to 3 centimeter posterior to the lower border of the mandible anteriorly, and you have to drain the pus. And fortunately, there is no any important mandibular structure in the submental area. There is no any neurovascular bundle, so it's easy to treat submental space infection. Just you give a small incision and you can drain the pus. And the submental space infection is usually associated with either infection of the lower anterior tooth or symphysis fracture. If the symphysis fracture is infected, it may lead to submental space infection. If there is any periapical lesion or lower anterior region, if it is associated with central incisor or lateral incisor of the mandible, then it may lead to submental space infection. So whenever there is collection of pus, we have to give the stab incision and drain it. The blade which is preferred for incision and drainage is, which blade do we prefer in case of a stab incision? So, usually you prefer 11 number blade for incision and drainage. And which blade do we prefer for any other surgery? While giving the incision over the, let's say if you have to raise the mucopharyngeal flap or if you have to give the submental incision, then we commonly prefer 15 number blade. In the maxillofacial region, whenever we are doing any surgery, we prefer 15 number blade. But for stab incision, we have to use 11 number blade, pointed blade. So while using 11 number blade, when you are giving the stab incision, you have to be careful. You must know the anatomical structure which is present near those areas. In case of submental area, you can use the 11 number blade. You can give the stab incision. If it is vestibular space infection, then also no problem. You can use 11 number blade and you can give the stab incision. But if you are giving submandibular incision, if you are giving retromandibular incision, then in such condition, never try to go more deeper. Don't try to use 11 number blade and don't give the stab incision, because you may damage the facial artery, facial vein, which is present in the submandible, just at the center of the incision area. There is presence of facial artery, facial vein. There is also presence of branches of marginal mandibular nerve. So in such condition, you have to give the incision only over the skin and submucous. After that, you have to do the blunt dissection, because once the facial artery is ruptured, it's very difficult to control the arterial bleeding. Arterial bleeding is always dangerous. It is projectile bleeding. You can't control the arterial bleeding with pressure, with any pressure pack or with any other medications. So there will be severe internal bleeding. In such condition, you have to be careful. So never try to do a stab incision if you are near any vital structure. Again, after incision, you have to drain the pus, collect the pus, and for culture sensitivity, you have to put the drain, or you have to put any sterile gauze. You have to do the dressing, then start the empirical therapy. Once you get the report after 24 hours, 48 hours, culture and sensitivity report. Then based on the culture and sensitivity report, you have to start or change the antibiotics. And here, if there is a space infection, you must prescribe antibiotics. In case of normal extraction, you don't have to, until and unless if it is associated with any space infection. If there is pericornitis, if there is buccal infection, space infection, or if there is vestibular space infection or vestibular abscess, in such condition you have to prescribe the antibiotic after extraction. But if there is no any infection, then never try to prescribe the antibiotics after routine extraction. Only the painkiller and mouthwash is sufficient, because it may lead to development of resistance, and once the patient has developed the resistance against certain antibiotic, it's very difficult to control when there is any severe infection. Because sometimes what happens, if you do the culture and sensitivity testing, all the bacteria will be resistant, all the antibiotics are resistant to those bacteria. Next is parotid space infection. Parotid space is bounded by the deep fascia, and the parotid space consists of parotid gland and the branches of facial nerve. Okay, in case of parotid space infection, also again you have to give the incision just anterior to the external ear. You have to do, after giving the skin incision, you have to do blunt dissection. So once the blunt dissection is done, the pus is collected, sent for culture and sensitivity. Again, same thing, start empirical therapy, start dressing. After the report, you have to change the antibiotic based on antibiotic sensitivity testing report. And the good thing is, in case of a space infection, as soon as you drain the pus, the patient will feel relieved. There will be no pain. In case of vestibular abscess, it is also easy to treat. First, you have to give the stab incision over the vestibule. You can drain the pus. Once the pus is drained, there will be no pain, and then you have to start the medications. If there is lateral pharyngeal space, you have to give the incision just medial to the pterygomandibular raphe. Okay, what are the structure which is attached to the pterygomandibular raphe? Or what is the origin and insertion of lateral pterygomandibular raphe? It's originated at the hamulus of pterygoid plate superiorly, and it gets inserted into the anterior border of the ramus just posterior to retromolar pad. Its importance is in the pterygomandibular raphe. In pterygomandibular raphe, anteriorly there is attachment of basilar muscle, and posteriorly there is attachment of superior pharyngeal constrictor muscle. And whenever you are giving the inferior nerve block, you have to penetrate through the basilar muscle, not the medial pterygoid muscle. Okay, you have to enter through the basilar muscle, and you have to reach the pterygomandibular space. So significance of pterygomandibular raphe is there is attachment of posteriorly there is attachment of superior pharyngeal constrictor muscle, and anteriorly there is a presence of basilar muscle. So you have to give the incision just medial to the pterygomandibular raphe, and you have to drain the lateral pharyngeal space infection. Next is Ludwig's angina. By definition, it's a bilateral, acute, rapidly spreading, septic, inflammatory, indurated, wooden, hard, or browny cellulitis of floor of mouth, simultaneously involving submandibular, submental, and sublingual spaces bilaterally. Okay. It was first described by Wilhelm Friedrich von Ludwig in 1836, but the term Ludwig's angina was coined by Kammerer in 1837. So it is a very dangerous condition where the bilaterally submandibular space, sublingual space, as well as submental space is involved. Okay, the tongue is raised, there is protruded tongue, patient could not open the mouth, there is trismus, there is brawny induration, hard induration is present in the over the bilateral submandibular area, and it's rapidly spreading. It may lead to obstruction of the respiratory tract. So there may be chances of airway obstruction. And in most of the Ludwig's angina, the death of the patient is due to respiratory obstruction. It obstructs the airway. So whenever there is Ludwig's angina, you have to treat immediately. The first thing is you have to protect the airway. For that, you can do either endotracheal intubation. That is, you can't do oral intubation. You have to go for nasotracheal intubation. After nasal intubation, or if the nasal intubation is not possible because you need there's something called as fiber optic instrument. You can blindly insert the nasotracheal. You can blindly insert the nasotracheal tube. It's very difficult. If you can't insert the nasolateral tube, the next option is you have to do tracheostomy. You have to secure the airway. Once the airway is secured, you have to use the tracheostomy tube. Then you can proceed for incision and drainage. During Ludwig's angina, you have to give the incision bilaterally in the submandibular region, submandibular incision, as well as when you are giving the submandibular incision, you have to do blunt dissection, and the most important thing is you have to reach up to the sublingual space. Through the skin, you have to dissect the platypus muscle, then investing fascia. Once you reach the submandibular space, you can drain the submandibular space, but that is not sufficient. You have to again separate the mylohyoid muscle as well. You have to go through the mylohyoid muscle, you have to enter the sublingual space. So your instrument should reach the floor of the mouth, so that the pus or infection which is present within the sublingual space is also drained. And you have to drain bilaterally. After that, you have to use the red rubber drain. Place the drain, then you have to do irrigation for either 8 hourly or 12 hourly. Again, the same thing, send for culture sensitivity testing, start IV medications at least for 3 days. Once the infection has been subsided, the swelling has been subsided, then you can change to oral medications. So in case of Ludwig's angina, as you can see, the submental space, this is the mylohyoid muscle. The space which is present over the mylohyoid muscle is sublingual space. Okay. And the genuhyoid muscles is the muscles of tongue, both the submental space as well as sublingual space, as well as anteriorly in the medial side, the submental spaces are involved. And due to the presence or accumulation of pus, there is brawny induration, hard induration present in the submental area, as well as tongue is protruded, as well as it is elevated, so patient could not open the mouth, and there will be severe pain. And in the latter case, it will lead to obstruction of the airway. So clinical features of Ludwig's angina are there is form, brawny, bilateral board-like edema, ill-defined borders with induration. It is non-fluctuant. There is involvement of submandibular, submental, and sublingual spaces. There is trismus, patient could not open or close the mouth. Tongue may be raised against palate due to involvement of sublingual space. There may be fever, dysphagia, patient could not drink or eat, impaired speech, and hoarseness of voice. Airway obstruction may be present. Increased respiratory rate due to hypoxia and hypercapnia, cyanosis due to progressive hypoxia, and death may occur in untreated cases due to hypoxia due to respiratory obstruction. So in case of Ludwig's angina, death of the patient mostly occurs due to obstruction of the airway. So there is respiratory obstruction. Treatment is, it should be taken as a life-threatening emergency situation, best treated by aggressive intervention. Treatment is based on combination of following factors: early diagnosis, maintenance of patent airway. Either you have to do fiber optic intubation, avoid blind intubation, or if you can't do the nasal intubation, fiber optic intubation, if the instrument is not available, then you have to go for tracheostomy. You have to secure the airway. Then intense and prolonged antibiotic therapy, extraction of funding teeth, surgical drainage of facial spaces. So first thing you have to do is you have to secure the airway. You have to do incision and drainage, and for culture sensitivity, you have to prescribe the medication, antibiotic, IV medications. Once the infection has been subsided, once the patient can open the mouth, once the mouth open is sufficient, then you have to find the etiological factor. Most commonly due to carious teeth, or maybe due to any infection. You have to find the cause. If it is due to carious teeth, you have to extract that teeth. So site of incision and drainage in case of a space infection. You have to give the incision over the temporal area, making an angle of 45 degrees. It's oblique incision, and it is present between the anterior and posterior branch of the superficial temporal artery. This incision is preferred whenever there is superficial deep temporal space infection. In case of either superficial or deep temporal infection, you can give the incision over the temporal area. You can drain the superficial temporal space. If the deep temporal space is also present, if infection is present, then you have to dissect through the temporalis muscle, and you have to drain the deep temporal space as well. Submental incision is commonly preferred because through the submental incision, you can reach many spaces in the maxillofacial region, right? The submental space, the sublingual space, the submental space, submasseteric space, buccal space, even lateral pharyngeal space. All the spaces can be approached through the submental incision. Similarly, if there is involvement of lateral pharyngeal, space, or if there is infection or carotid cyst, you can give the incision just anterior to the sternocleidomastoid muscle. These are the potential sites of incision and drainage of facial space infection. The space involved and the site of incision and drainage. In case of masticator space infection, you have to give the incision over the inferior border of the mandible, usually the submandibular incision. From there, the masticator spaces are the submastical space, the pterygomandibular space, or superficial and deep temporal space. All those spaces can be approached through the submandibular incision. If there is temporal space infection, you have to give the incision above the zygomatic arch. Both superficial and deep spaces can be drained through that approach. In case of submandibular space infection, you have to give the incision below the inferior border of the mandible in the submandibular triangle. In case of lateral pharyngeal space infection, you have to give the incision intraorally along the pterygomandibular raphe, or you can also approach through extraoral approach at the angle of the mandible. In buccal space infection, intraoral in the mandible mucobuccal fold. But if there is buccal space infection, it's better to give the extraoral incision. It is near the lower border of the mandible. You can break all the loculi easily, and all the pus can be drained through the extraoral incision. If you give the intraoral incision, it's slightly difficult to drain it to reach all the loculi. But you can try. Instead of giving the extraoral scar mark, it's always better to approach through the transoral approach or intraorally. In case of paramandibular incision, paramandibular space infection, you can give the incision intraorally in the buccal sulcus. In infratemporal space infection, incision is given above and lateral to the maxillary tuberosity. Complications of orofacial infections are related to upper jaw. It may lead to cavernous sinus thrombosis, it may lead to brain abscess, or it may lead to meningitis. These are the serious conditions. And related to lower jaw, it may lead to Ludwig's angina, or mediastinitis, or carotid sheath invasion. Okay, this table summarizes the overall boundaries of the facial spaces. Okay, you have to read all those. So before reading this table, you have to know its anatomy. You have to see the figure. Once you see the figure, it's better to understand. You don't have to memorize all this. Once you remember the figure, it's very, very easy. And on the relation of deep facial space infection, the spaces which are present, the likely causes, the contents present in them, the neighboring spaces. Those neighboring spaces are secondary spaces, and approach for incision. These are all the summary. You have to read all three tables. Space infection is always a dangerous condition, so it's emergency condition. Whenever you find a patient with a space infection, you have to treat immediately. Once there is septicemia, then it's very difficult to manage.